Sorry. Oh. I don't think so. How are you guys doing tonight? Thanks for coming.
It's been a minute.
I don't see many. Well, is that a Christmas sweater? It's a Christmas shirt. That's pretty good. So
That's
maybe,
extra special.
yeah, maybe you'll get a low 5. Yeah.
All right. So last time we saw you guys was Immuno. How did it go? Good, bad? MSK going better? Maybe.
Worse.
I didn't like MSK compared to Immuno, but that's just a personal preference. So today we have our friend Matt who does anatomy. He's going to talk after us. So Dan and I are going to go over lecture stuff. I'm going to keep mine pretty brief, and Dan's going to focus more on like cranial nerve stuff, peripheral versus central nervous system, because that stuff is going to be a huge basis for this neuro and the HE&T course that you guys are going to have whenever you guys get back from Christmas. So we're going to kind of like prime you also, so don't get overwhelmed. All right, let's see. So the first one we're going to talk about is common regional rheumatic disorders. I tried to just go through the things that I thought were really high yield whenever we had the lecture and then had exam questions on it. So there were like 3 or 4 things I think that stood out to me in this PowerPoint, and one of them was just the median neuropathy. I think it's important for you guys to know the distribution that the median nerve is in the hand compared to ulnar, because there are going to be so many questions that they give you, both on your quizzes that you've probably already had, as well as your final exam, where they're going to tell you which fingers they can feel or can't feel, and you're going to have to be able to tell like where the injury is, if it's median or if it's ulnar, or like where along the tract it would get injured. And then also knowing the 3 muscles that are atrophied when it comes to median neuropathy. It's all the ones that are innervated by the median nerve. So it's the abductor pollicis brevis, flexor pollicis brevis, and opponent pollicis brevis. So make sure you guys know those, because it's kind of hard, or it's kind of easy to mix them up with other muscles that also sound the same. And then you'll probably get asked about Phelan's and Tinel signs. So I just put a sign below here, so in case you guys don't remember what it is. The Phelan's is whenever they kind of put their hands at a 90-degree angle and they get pain. And then the other one is just tapping. And then this is also a very high yield one. I think we've had multiple questions about this. Hang on. Is anybody muted?
Oh, yeah. I guess make sure if you're online, make sure you're muted. I guess I heard a little sneeze.
No, it's okay. I didn't know if that was
it's kind of fun though, actually. Maybe.
Yeah, it's kind of fun. So knowing, like I said, just the tendons that are affected, and then the maneuver that you would do in order to show that it's de Quervain's. And also look for this in people that are like gaming. They use their thumbs a lot. It's like one of the buzzwords that you'll get in a vignette where it's like, this person does a lot of work with their thumb and they have pain. What would it be? So make sure you guys understand what de Quervain's is. And then we had a question on tennis elbow last year. I think it was lateral epicondyle, but just know that whenever you have pain on the lateral side, it's lateral epicondyle, medial side, median epicondyle. I know that median is the flexion, so the flexor muscles, and then lateral is the extension muscles.
So I'm a tennis player, and so when you hit your backhand with the one hand, you come over the ball with your wrist, and that's what causes the thing. And then the golfer's elbow is
that's the median one.
So yes. You come over, you flex your wrist. So that's why those are there.
Yeah, sometimes, and I don't play either of those sports.
No,
thank you.
That's not true. You play sports.
Not those ones. All right. So now we're going to just talk a little bit about gout and fibromyalgia. So just understanding that gout or crystal arthritis, gout/pseudo-gout, is based on the accumulation of uric acid, which comes from purine degradation. And the major enzyme that's involved in the production of uric acid is the xanthine oxidase. So this is the one that converts hypoxanthine to xanthine. I put a little arrow there. Just so you guys know, I think it's really high yield for you to know that that's a big drug target for gout, especially allopurinol. That's one of like the favorite drugs for gout. So just understanding that and like why you would use it for gout. So you want to decrease uric acid so that you don't have such high levels. By decreasing the production, you decrease the levels. And then I strongly recommend you guys understand the stages of gout. I know it seems pretty self-explanatory, but I'm pretty sure there were a couple questions on different stages of gout, like knowing what asymptomatic hyperuricemia is, knowing that it's just high levels, but there's no symptoms, obviously, from the name, but knowing that there's no treatment that's needed for asymptomatic hyperuricemia, and you don't start treating until you actually get the acute flare-ups. And then also knowing that the intercritical gout, that's the periods in between your acute attacks, knowing that that's kind of one of the goals of treatment is to prolong the intermittent periods so that you have less acute attacks. This is mostly from your slides. And I would say that if you hear the word TOFI ever, you should automatically put gout. Because I know that they often like to use TOFI as an indicator for gout as well. So look for an older man, pain in the toe, pain in the knee, unilateral, red, swollen, worse at night. That'll give you kind of indicators that it should be crystal arthritis or gout.
Something I'll say too briefly on that. So TOFI, it's really only seen if you don't treat your gout and you don't take care of it. But say, you have chronic gout for a really long time, that's when you start to see those TOFI. You're not going to see a patient come in with an acute gout flare who's never, had any flares before. It's like a chronic thing. Right. So you won't see TOFI .
Yeah, and presence of TOFI is actually what characterizes gout as chronic. Yeah. So this is a really important slide. You should know this in many ways. You should know the white blood cell count, the clarity of it, knowing crystals, because they will ask you or give you synovial fluid, like either the color or the composition of it, and you have to know if it's normal or if it's just degenerative arthritis or if it's going to be inflammatory. So obviously, if you have inflammatory, you're going to have increased red blood cells, and it'll be probably more opaque, and then septic gets even more opaque. So just understanding how interpretations of synovial fluid analysis can help point you in the right direction of what kind of arthritis it would be. Because I know that Dr. Hurley liked to talk about this a lot, and I think he may have stressed it in our lectures last year, but it was on a couple quiz and test questions. Probably. I just pulled it from the slides. Yeah, I feel like it would probably be a plus. Good question, though. Okay, this is high yield. You will get so many questions about this. You need to know how to treat gout, how to treat acute gout, how to treat chronic gout, what works, what doesn't work, what stops the progression, and what doesn't stop the progression. So we'll start with acute gout. Well, first I said, if you have asymptomatic hyperuricemia, no treatment. You don't need to treat it. But as soon as you get to an acute flare, you have three options. You can use NSAIDs, you can use steroids, and you can use colchicine. And NSAIDs will help with the pain, so it'll help decrease inflammation, but it does not stop the progression of the gout. And then they also say that you shouldn't use aspirin, which is also pretty important because the reason why you can't use aspirin is because it interferes with the renal excretion of uric acid, and it actually decreases excretion of uric acid, so it'll make your gout worse if you take aspirin. And then the quiz question that you will probably get is knowing whether or not you can use colchicine. And the only time you can use colchicine is acute gout, not intermittent, not to prevent future attacks, acute gout with symptoms less than 36 hours. So if they give you someone and they're like, I want to control my gout, how do I do it? Not colchicine. Colchicine's only for acute attacks. That's a big trick question that they got me on last year.
Remember those kind of things?
Yeah, they stick with you for a long time. And then the other one is the attack, preventing future attacks. So this is when I said you want to prolong the intermittent periods between acute attacks, and that's kind of one of the big goals of gout. So you want to treat acute, and then you want to prolong the intermittent periods. And to do that, the most common one is the xanthine oxidase inhibitors like allopurinol. And that's what you would use for chronic gout to prevent future attacks. So knowing allopurinol is a xanthine oxidase. I know he said probenecid in his Dr. Hurley's lecture. I don't know if you guys really need to know that. It's a second line. You only use it if you need in combination with xanthine oxidase inhibitors or if xanthine oxidase inhibitors don't work.
There's a couple other ones I just want to mention. There's pegloticase and rasburicase. Those are actually really good, but they're super expensive. So what they do is they take uric acid and they convert it to allantoin, which is, it doesn't have any crystal forming properties, but it's really tough to get. It's just really expensive. So they don't use it that much. But in case you hear rasburicase, pegloticase, that's what those do.
I think rasburicase would be a good one to know. I think they gave you that one maybe once or twice. But I didn't include that one here just because it's so expensive. And I feel like allopurinol versus colchicine, knowing when to use each one is the biggest part. So then I just summarized it for you in case you guys didn't want to read the long slide about all of the treatments because I wouldn't want to. Okay, and then this is also really high yield. Knowing the difference between a pseudo gout crystal and a crystal gout crystal, both composition and the like makeup of it, knowing that uric acid or monosodium urate is gout, and then the calcium pyrophosphate dihydrate is the pseudo gout. You will get questions on this probably on your quiz on Friday, as well as your final exam. They'll probably give you either the like the polarized thing, or they'll tell you, or they'll say like, what is the crystal that causes this? And then you'll have to know what the makeup of it is. So make sure you guys know both of those. And whenever they give you the polarization, the urate crystals or the monosodium urate that causes gout, they're not birefringent, so they don't polarize light, and they're needle and rod shaped, whereas the ones for pseudo gout are rhomboid shaped. So they'll most likely give you rhomboid because that's kind of a big, whatchamacallit, keyword. What do they call those again? Never mind. Anyways, never mind. My brain's not working.
Oh, you're good.
Like a buzzword. I said it earlier.
That's it.
Okay.
Yeah. So big takeaway, just think gout, negative birefringence, calcium pyrophosphate, positive birefringence. So gout is negative, pseudo gout is positive. Okay. Those are big associations.
Yep. And that's the big way to dissociate between the two, because a lot of times they'll present the same because they're both kind of like gout. They're both accumulation of crystals in your joints. So one of the ways that you can differentiate them is by looking at the crystals. And that's also the gold standard for diagnosing both gout and pseudo gout. So make sure you know that, put a little star next to it. And then this is also high yield because this is something that I missed last year. So fibromyalgia, you guys know that it's most of the time it's a chronic pain disorder, females. There's usually never really findings that correlate with the pain that they have. And it's most likely due to like increased excitatory transmission or setting a new threshold in their CNS system. So knowing how to treat it is really important. Knowing that NSAIDs themselves are not just treatment for fibromyalgia, because it is in fact a real condition that you do have to treat. So NSAIDs probably won't work. And you also don't want to give them narcotics because the pain is bad. They will get addicted to them. We don't want more problems than just the fibromyalgia. So knowing that you give pregabalin or gabapentin, as well as duloxetine, to either decrease or increase excitatory or inhibitory transmitters. So make sure you guys know that as well. And then this is for your fun times. You guys can look at it. Okay.
We go back because they don't have access to it.
Oh, never mind. You guys can look at it.
Give it like 30 seconds.
It is really difficult to find memes with like arthritis and stuff. They don't make jokes about that stuff.
Yeah, I guess it's pretty sad.
Yeah, there were some funny House ones. I don't know if you guys watch House at all, but there's a lot of memes about lupus on that one. So if you guys want to look that up, just type in lupus memes. That's what I did all of yesterday. Okay, so I know you guys have probably learned about this like a million times. You probably learned about it in foundations. You're going to learn about it now, and you're going to learn about it again next semester. You're just going to learn about it all the time. So these are really important things to differentiate between osteoarthritis and rheumatoid arthritis, or degenerative joint disease is what they call it now, I think. So knowing the presentation as well as where in the fingers, or not fingers, but like the hands, what joints are affected in each type of arthritis, because that's something that they will give you over and over and over again. And you don't even need the rest of the vignette if you can see like which joints are affected and whether it gets worse or better with activity. That can easily clue you in between the two, because they will test you on like differentiating the two. So rheumatoid arthritis, we're just gonna go through this pretty quick, but if any of you guys need any further explanation or confused or anything, me and Dan and maybe Matt would be happy to explain it to you. But rheumatoid arthritis is more in older women, I would say, but it's an autoimmune disease. And they wake up and they're very stiff, and it takes a really long time for their joints to like warm up and become less stiff. But as they do more activity, the pain starts to get a little bit better, which is the complete opposite of osteoarthritis, where they wake up stiff, but it goes away pretty quickly as soon as they start moving. But then the more they do weight-bearing exercises or walk or really do anything, the pain gets worse. And that would make sense because osteoarthritis is where you have degeneration of the cartilage in between your joints. So your bones are moving, like rubbing against each other. So the more you're walking, the more your bones are rubbing against each other, the more pain you're going to get. And then knowing that rheumatoid arthritis is more often in the small joints. So like the small joints of the hands, the wrists, the ankles, whereas osteoarthritis is in the hips and the knees and the really big weight-bearing joints. And then the biggest high yield thing on the slide is what I put super important underneath, which is knowing that rheumatoid arthritis is going to affect the MCPs and the PIP joints, whereas osteoarthritis is your dips and your pips. So knowing that differentiation will help you a lot between those two. Does that make sense for everybody? Cool, cool, cool. All right, this can get a little confusing, but pretty much diagnosing rheumatoid arthritis is really hard, and there aren't really very many tests that you can actually use because rheumatoid factor is sensitive. It'll pick it up, but it is not specific for rheumatoid arthritis. It's present in a lot of other things like Sjogren's, mixed cryoglobulinemia, random other things. Some people just have it for fun, or they get it whenever, like as they age, they'll develop rheumatoid factor. So you cannot just rely on the positive rheumatoid factor in order to diagnose rheumatoid arthritis. But the anti-cyclic citrullonated peptide, or anti-CCP, this one is specific to rheumatoid arthritis, but it's not always present. So some people can have rheumatoid arthritis and still be negative for both of these. But one important thing to know is that if they're positive for either one or both of them, it correlates with a worse prognosis. So they'll have much more severe disease if they're rheumatoid factor positive or anti-CCP positive or both. And then rheumatoid arthritis is also autoimmune. So you're going to have a lot of inflammation. So in your blood work, you'll probably have an elevated CRP and erythrocyte sedimentation rate. So those are both just non-specific markers for inflammation, but they'll most likely be elevated in people with rheumatoid arthritis. But again, not specific. All right. You what? Oh, okay. Okay. And then knowing the treatment for rheumatoid arthritis, I don't think you need to know like what each biologic's name is, like the brand name or the generic name, but you need to know which medications you can use to stop the progression of the disease and which ones will only help with symptoms. So I put in red the like major things that you guys should know. So using NSAIDs, it's pretty similar to gout. It helps in the pain because it's inflammatory disease. So it will decrease the inflammation and help with the pain, but it does not stop the progression of rheumatoid arthritis. So you never put someone on rheumatoid arthritis without putting them on some kind of steroid or DMARD, as Dr. Hurley calls them. So never use NSAIDs by themselves because they won't do anything for the disease. They'll just help with symptoms. And then steroids, you can use very short term. If you guys have probably already learned this, but steroids are really bad. Like they're really good if you need them really short term, but they have so many bad side effects for your body that you just don't want to use them unless you absolutely have to. So if you use corticosteroids, they don't really help with the progression of the disease, but they help to get it under control. So you can like pair it with a DMARD, and then as soon as the rheumatoid arthritis gets better or like gets more under control, you take out the steroid and you just keep the DMARD to keep them in remission or at a low state of disease. Because DMARDs and biologics, they will halt and or slow the progression of the rheumatoid arthritis, which is pretty unique to these two things. So knowing that methotrexate will stop the progression of rheumatoid arthritis, so it will help keep them from getting the whole ulnar deviation or swan neck look to their hands and all the other deformities that come with rheumatoid arthritis. So the biggest thing with rheumatoid arthritis is making sure you try to diagnose early, it's a goal for everything. So you can't really say that's specific to rheumatoid arthritis, but you want to treat really aggressively as early as possible. So you want to use combination therapy. You want to start them on a DMARD as soon as possible. And you want to like treat it as if they're going to like wake up the next morning and not have a hand or something. You want to like do it really well.
Something I'll say briefly about corticosteroids too, especially with rheumatoid arthritis. So it's more the oral steroids that we're concerned about, is those systemic steroids. But if you can do like corticosteroid joint injection, that significantly reduces a lot of those negative side effects. So you'll see that's just like a practical thing to know, route of delivery of those drugs. So
yep, no, that's very true. And they also use those kinds of injections for osteoarthritis too. Okay, so we're going to do a quick recap from Immuno because I know you guys had so much fun with us last time. So even if this isn't on your quiz or exam, this is so important for you guys to know because you're going to get questions on it all throughout medical school. So knowing what type of hypersensitivity reaction lupus is, knowing that it's a type 3 hypersensitivity, which means that you have immune antibody complexes that are getting deposited underneath the skin or in the joints or in the organs. And that's part of the reason why lupus is systemic, because you form the immune complexes in your blood and then they can straight up go anywhere. They can go in your knees, they can go in your liver, they can go in your lungs, they can go in your face and cause your butterfly rash. So knowing that it's type 3 hypersensitivity, and then fun fact that it's Th2 dominant, and we know that whenever a woman becomes pregnant, her immune system shifts to Th2 because you want to give the baby antibodies, so you're going to produce more antibodies. So lupus is one of the autoimmune diseases that gets worse in pregnancy, not better. Okay, so I'm sure you guys have learned about lupus quite a bit. Classic presentation is going to be a woman probably in her 20s or 30s, comes in, has photosensitivity in the sense like she gets a really bad rash in all sun exposed areas. That's a pretty common thing that they'll say. And they'll describe other non-specific symptoms like fever or chest pain or random other things because it is systemic, but you just need to hone in on the major things like a photosensitive rash, a butterfly rash, the age, the gender. Those all kind of point you towards lupus. And then I got this from the USMLE. It's just like a classic patient presentation in case you guys want to read it. Just in case you guys like are having a little trouble like identifying what to like focus on in a vignette. So like seeing that she's female, she's in her 20s, butterfly rash all over her face, and then photosensitivity would be the things that I would focus on if I were taking the exam.
Yep, and the joint swelling as well is good.
Yeah.
Especially.
Yeah. And then the other thing with lupus is that it causes arthritis, but it's symmetrical and it's migratory. So it's different from rheumatoid arthritis in that it's migratory. So it can go in one joint one day, a different joint another day. And it's also not fibrotic. Like it doesn't like permanently damage your joints. It's actually reversible arthritis if you treat the lupus. So this is also just another thing that I thought would be helpful if you guys are having trouble like understanding all the different kinds of things that you can see in lupus. It's just like I got this chart from USMLE. I think I got a couple charts from USMLE. If you guys are interested in reading them, you absolutely don't have to. But if you guys are like just wanting to understand it a little better or have some clues in your mind about what to look for in vignettes, this would be a helpful slide just to see all the things that lupus can do. And then this is really high yield for you guys to know. It's probably one of the things that they're going to test you on quite a bit. And it's how to diagnose or like the different markers that you can use in lupus. So they really like to trick you and say that, like ask you a question, and in the vignette, they'll put the person as ANA positive and they'll make her present as like a lupus patient, like with arthritis or a fever or chest pain. But ANA by itself is not specific to lupus. It is present in a lot of other diseases, and even some drugs can produce ANA in the body. So ANA by itself does not mean lupus, because people with even rheumatoid arthritis can have ANA positive. So don't focus too much on that in a vignette because it's not gonna necessarily point you towards lupus or something else. But the other ones, I don't know if Dr. Hurley went over this very much, but I want to say that we had a couple questions about it from probably Dr. Hurley as well as in like cardio or something. So you have double-stranded DNA. And so this is one of the markers that you can use, and it's specific for lupus, and it's associated with active disease. So it will be present if the patient's having like a lupus flare, which is different than anti-Smith, because anti-Smith, it's present in a small fraction of patients. Like none of these patients are going to be perfect. None of them are actually going to have all of these markers, but in a perfect world, they would have an anti-Smith antibody. But you can't use an anti-Smith antibody to monitor treatment because it doesn't change with different severity of disease. It will just be present if they have the disease, not present if they don't. So if they ask you what marker to monitor in order to see if treatment is being successful or not, don't pick anti-Smith because they don't change with different like disease activity. And then just, I guess another thing, complement whenever you have a type 3 sensitivity reaction and you have the immune complexes getting deposited, that activates complement. So if someone's having a really bad flare-up of lupus, that means that they're having a lot of immune complexes, which means that a lot of their complement system is getting activated. So they're using up all of their complement. So in active disease, you're going to have decreased complement levels. So you're going to have a decrease in C3 and C4. So that can also help you to monitor like active disease versus not active disease. And then treatment for lupus. This is pretty similar to rheumatoid arthritis in the sense that steroids and NSAIDs don't stop the progression. They're just used to control inflammation and help with symptoms. So you want to use immunomodulators. I don't know if they want you to know the specific names of them, apart from hydroxychloroquine, because Dr. Hurley loves hydroxychloroquine. He said it like 6 times in our lecture last year. I went through your guys, or I guess our PowerPoint slides, hoping that they're the same from last year. And I wrote down like 6 times, like all patients with lupus should be on hydroxychloroquine. It's like the most common used drug. So if they ever ask you what to use for lupus, probably pick hydroxychloroquine. And then now Dan is going to talk a little bit.
All right, so I actually didn't have access. These are new lectures that you guys had on the peripheral nervous system. So I don't have access to what you were given. So I decided that I was just going to introduce the peripheral nervous system, and some of this may be review, some of it will probably be new. The meat of this is going to be cranial nerves, and I don't want you to freak out because they're kind of complicated, but I want to provide you with like a baseline understanding and something you can come back to when you go into HENT and neuro, because I remember last year, they kind of just threw them all at us one day and we're like, all right, 3 days later, you have to memorize everything. So it was kind of crazy. So
yeah, so while Dan's going through this, don't think that you have to know all of this by Friday. Just correlate it with your lecture, but we just want to give you more information than we had last year because HENT was not fun for us.
Brutal.
Yeah.
So I hope this helps. So start off. It is, but we're not going to study the brain. We're going to study the peripheral nervous system, which is not the brain. So the central nervous system, right? Brain and spinal cord. Then we have peripheral nervous system, can be subdivided into autonomic and somatic. And then you subdivide into sympathetic, parasympathetic. Okay. This is another good slide. This details more the peripheral nervous system. So they divide it here into motor and sensory, which I kind of like because that makes a little more sense to me. So when they say autonomic and somatic, they actually group the sensory into somatic and they combine it with the skeletal or voluntary motor. So if you see this, this is how they're grouping it. And then just once again, sympathetic, parasympathetic. Enteric nervous system is its own thing. Don't worry about that. You'll learn about it. They still don't know a lot about it, so it's kind of one of those things that they actually don't test you on that much because it's so. But anyway, okay, let's talk about some terms. So when I say peripheral nerve, what I mean is a collection of axons and support cells. We'll talk about what those are that are outside the central nervous system. Okay, you guys have been looking at peripheral nerves for, I don't know, 7 weeks or something. So I hope that it'll be more fun to kind of know what's in there now. So there's 2 types of peripheral nerves. There's a spinal nerve, which communicates directly with the spinal cord. And then you have a cranial nerve, which communicates with the brain stem or directly with the brain. So we'll talk about those a little more. You can also subdivide based on the direction that the information is being carried. So we have a sensory neuron, also called afferent. I like to think afferent is arriving. So it carries information toward the CNS from the periphery. And then on the other hand, we have motor neurons, which carry information away from the central nervous system, controlling muscles, either voluntary or involuntary. So we have like our somatic motor neurons controlling skeletal muscle. And then we also have the whole autonomic nervous system, not under voluntary control, controlling smooth muscle, cardiac muscle, and glandular secretion.
And just to add to that, if you guys are having trouble with like afferent versus efferent, motor versus sensory, you've probably already heard it, but it's a mnemonic called Same Dave: sensory afferent, motor efferent, and then dorsal afferent. Well,
yes.
Dave, ventral efferent. Yes.
That's right.
So if you guys are having trouble, I always struggled with it. So Same Dave has saved me both last year and this year, surprisingly, because we got a couple neuro questions.
Mm-hmm. The dorsal afferent, ventral efferent, we'll talk about more when we talk about spinal nerves specifically. And then a ganglion. This is important, okay? This is one of those foundational principles I want you to take because I didn't know what a ganglion was until like halfway through HENT, and it was a real bummer. So you're gonna know what this is. So it's what it is. It's a collection of neuron cell bodies that are outside the central nervous system. Okay, so that'll be important when we talk about autonomics and when we talk about sensory neurons. Okay, they're both involved in ganglion. Their cell bodies are outside the spinal cord. So I'll show you lots of nice pictures. I like this picture because it makes things nice and simple, which I have a simple mind, so I like it when I can understand it. So this is very, I mean, it's very brief, but when you see something, you appreciate it visually. You think about it, like you see this water glass, and then you reach out, you grab it. Or in some cases, like if this is like a hot surface and you touch it, then you don't think about, I'm touching something hot, I should move my hand. You just do it. The reflex arc kicks in and you just take your hand away because it's burning and your skin is blistering. Hopefully not too bad. Yeah, and the other thing too is, I like to think that if I see like some carrot cake, it kind of just goes through the reflex arc. And I don't really think about it. I kind of just see the cake and I just grab it, and then I put it in my mouth. So I don't have any evidence to back that up, but I'm pretty sure it's a thing. So I don't know if you all have some sort of food like that, but anyway, so there's a lot about the brain we don't know. So that's all I'm saying. Anyway, so let me just make sure we don't, okay, no questions. So the CNS and PNS, okay, so central nervous system is brain, spinal cord, and then brainstem. So peripheral nervous system, we have the cranial nerves coming out of the brain and brainstem. They're not pictured here. This is from first aid. So, and then spinal nerves coming out of the spinal cord. And then these ganglia, these all important ganglia. We're gonna keep looking at them. Okay. There's only 3 cells in the peripheral nervous system, which is great. There's a neuron, there's a Schwann cell, and then there's a satellite cell, but we're not gonna talk about satellite cells because I don't think that they're really that important. So first, neurons. I hope you all know what a neuron is. It is the functional unit of the nervous system. It carries information in the form of electricity. Have you all had like a neurophysiology lecture yet at all? Any like how they depolarize and send their signals around? Maybe, sort of. One slide. That's not very much. Okay, well, neurons, okay, so they send information in the form of electricity, and they do it by depolarizing. And it's sodium that they use, sodium channels. And we'll look at a picture of that. There's 3 parts to every neuron. There's the cell body, which is where the nucleus is. There are the dendrites, which carry information from other neurons that attach on through synapses. They attach on to the dendrites, and then they send their electrical signals down to the cell body. And then the neuron will integrate all the signals coming in from the dendrites and send its signal down in one axon. Every neuron only has one axon. So it integrates the signal, sends it down the axon to another neuron or a muscle in the case of skeletal muscle. This is what it looks like underneath a microscope in case you like that sort of thing. Oh, they do. Yeah, that's true. So hopefully, yeah, you've seen a picture of a neuron before, but yeah, you can see the dendrites, cell body, and then a singular axon. Some neurons only have like one dendrite. Some have a lot. It just depends. Let's look at that in a little more detail. So this is like the key I want you to take away from this talk. So depending on what type of peripheral neuron you're dealing with, it tends to adopt a certain configuration. Oh, no. So first off, we have our motor neurons, our efferent neurons. So somatic motor neurons adopt this one neuron, one axon approach to stimulating skeletal muscle. So I use the term multipolar. You'll hear that. And what that means is you just have more than one process coming off of the cell body. So it just means you have an axon, but you also have a bunch of dendrites. They're not pictured here. I don't know, missile bodies, don't worry about that. But yeah, so the point is one neuron coming from the spinal cord out to skeletal muscle. Okay, yeah, so I said that here. So the cell body of a skeletal motor neuron is in the spinal cord. Okay, important. Now, when we look at the autonomic motor system, it's a little different. So we actually use 2 neurons for this. I don't know why. It's the way our body's set up. So we have what's called a presynaptic neuron, okay, that starts in the spinal cord. This cell body will be in the spinal cord. And then what happens is it sends out an axon and it attaches onto a postsynaptic neuron. And this cell body, where would this be located? What's my favorite word? Ganglion, good. Okay, so this will be in a ganglion somewhere. Okay, so that's important. So anytime, well, not anytime, so a lot of the ganglia you see, particularly in the cranial nerves, are autonomic. Okay, there's also some sensory. We'll go over some of that. But 2-neuron system. Okay, so presynaptic, postsynaptic, and then remember our autonomics do smooth muscle, cardiac muscle, and then glands. Okay, not under voluntary control. Okay. Next, we have the sensory neurons. Okay, so those are carrying information back toward the spinal cord. Most of these are either pseudo-unipolar or bipolar. So they're, once again, their cell body is going to be present in a ganglion because this here goes over to the spinal cord. So their cell bodies will be outside the spinal cord. So both the autonomics and the sensory neurons will have ganglion. Okay, very important. It's actually, and for spinal nerves, the sensory neurons, their cell bodies are present in what are called dorsal root ganglion, and those are just right outside the spinal cord. I'll show you a picture of that. There's also these really fun special arrangements, but don't worry about those. You'll maybe learn about them in neuro. I don't know, but whatever floats your boat, you know. I kind of like the bottom one because you have a lot of pants, but they're also pretty big. So you get the most pants, you know? So I feel like the other two are kind of getting gypped a little bit, but anyway, whatever you want. Okay. Any questions about what I've talked about? Okay. Not the memes, I guess, you know, you can, those are, yeah. Okay. So Schwann cells are the other big cell that are present in the peripheral nervous system. Okay, their main thing, what they do is they surround the axons. Okay, they surround the axons of peripheral nervous system neurons. High yield to know is that they produce myelin. Okay, that's their big job. Myelin. So since you guys haven't had like a true like neurophysiology lecture, I'll just briefly explain kind of what happens here. So when the neuron is sending an electrical signal, it does what's called depolarizing. So voltage-gated sodium channels will open and the sodium will rush into the neuron, and then it will create this positive charge inside the neuron, and then it keeps opening sodium channels down the neuron, and the signal is propagated down the axon. So the nice thing about this myelin is that you don't need sodium channels along the entire length of the axon if you have myelin. The electrical signal gets to skip that section if you have myelin. So it really speeds up the conduction. Okay, so that's the high yield thing to know about Schwann cells and myelin. Okay, it makes your signals go a lot faster, it makes sense, right? I guess we'll get there. Oh yeah, so this is called, they like this term, it's called saltatory conduction. Okay, that's all that means is that you just have myelin insulating the axon, it's going fast. Okay, and then these little nodes where you have sodium channels are called nodes of Ranvier. Okay. They don't always produce myelin, Schwann cells do, or don't. In the case of like autonomics, they actually surround the nerves, but they're not myelinating them. So autonomic nerves are actually not myelinated usually. So therefore, you can imagine that the signals sent by those nerves are a lot slower, as opposed to sensory nerves and somatic motor controlling your skeletal muscle. Those are myelinated, and that should make sense because if you're touching something, you don't want to like wait 10 minutes and then feel it. You know, it'd be nice to just feel it right away. And then also, like if I'm doing like a bicep curl like 3 years ago, it's been a while. But yeah, it's not too bad. So like you want to be curling right away. You know, you don't want to like, I want to contract my elbow and then let it sit there for 5 minutes and then, oh, there it goes. You know, that'd be weird. So anyway, that's how I think about that. Autonomic nerves, it's a more broad response, but it's not as fast as a general rule. Okay, looking at just like the general arrangement of a peripheral nerve. You guys have seen them in the gross lab. Let's look at it a little bit more closely. Sorry. So we have axons. Okay, that's the big component. And it can be a combination. Not all peripheral nerves can carry like all 3 different types of axons. They can carry motor neurons like parasympathetic. They can carry motor neurons that are skeletal muscle. They can carry sensory neurons. They're all like bundled together. Okay, so a peripheral nerve isn't limited to just one type of axon. Okay, next we have Schwann cells, which we talked about. Okay, myelinating the axons. We also have some connective and elastic tissue. and that is subdivided into 3 different areas. So we have the epineurium, which surrounds the peripheral nerve. When you look at a nerve, that's what you're looking at grossly is the epineurium. Perineurium, which surrounds these bundles of axons, and then the endoneurium, which surrounds individual axons, that kind of yellowish stuff. And then we also have some blood vessels supplying the nerve in the epineurium. Okay, so that's your general arrangement of a peripheral nerve. Not too bad, right? Okay. Now I'm going to talk about autonomic nervous system in a little more detail. Okay, we kind of brushed on it. So it's motor, right? But they don't innervate skeletal muscle. They innervate smooth muscle, cardiac muscle, and glands. They're not myelinated. Okay, it's a 2-neuron system, very high yield, pre and post ganglionic, and then sympathetic, parasympathetic. Okay, so I just briefly listed out some of the differences. I don't know why I made it. So when you think of sympathetic, you guys maybe have heard this before, like fight or flight response. Okay, it's like your arousal state. Parasympathetic is rest and digest and secrete. I like to think because it makes stuff come out of glands, so therefore it secretes it. And then, so this is important to know, and you'll keep coming back to this. Don't feel like you have to memorize these now. I don't know what they gave you in lecture, but for the sympathetic nervous system, the preganglionic neuron cell bodies, they're in the spinal cord, right? Because they're preganglionic, but they originate at the level from T1 to L3, okay? And I'll show you a picture about that. Whereas parasympathetic, they either originate, the preganglionic cell bodies are either in the brainstem, and we'll see that when we look at the cranial nerves, or they're in the sacral spinal cord levels S2 to S4. But don't worry about that for now. We're going to talk about the cranial nerves. This will become more important when you do like your GI stuff. Okay, so then looking at the postganglionic neurons then, the cell bodies are in like the sympathetic chain, which is like, I don't know, I guess I've seen this in lab, probably not, but it's like a chain of ganglia that's right next to the spinal cord, and it's really close. So the point I wanted to make is that the preganglionic neuron for sympathetic nervous system, those are really short, okay? And then afterward, the postganglionic neuron is really long. So it's a short and then a long. As opposed to parasympathetic, which is the opposite, the postganglionic neuron cell body is in a ganglia that's close to the target organ, okay? So the preganglionic neuron is much longer than the postganglionic, okay? I'll show you a picture about that. So this is I don't know if this slide was given to you. It was given to us last year in our intro to autonomics lecture. I like it because it's not too crazy. Let me just talk through it with you guys. So looking at we have our autonomic nervous system here up top. We have the sympathetic division is this top box, parasympathetic here, and then the somatic. So somatic we talked about is one big neuron, right? Coming from the spinal cord all the way to skeletal muscle, and that's it. It's one neuron, but autonomics is 2. So we have, first off, this is important. So most of the time, a sympathetic neuron, a postganglionic neuron will use norepinephrine as the transmitter, okay? Norepinephrine sympathetics, except in sweat glands. Sweat glands are technically sympathetic, but they use acetylcholine, okay? In the postganglionic neurons. So all preganglionic neurons, all of it is acetylcholine, okay? But postganglionic is where you get the differences. Don't worry about the adrenal medulla for now. And then with parasympathetic, we have a long presynaptic, short postsynaptic, and then acetylcholine is exclusively used. Okay. And then they'll talk to you about the different types of receptors, muscarinic and alpha and beta. I don't want to talk about that right now. Don't freak out. So this is just, everything I have said is in this picture. So T1 through L3 for the sympathetics in the spinal cord, okay, preganglionic, T1 to L3. Then it goes to the sympathetic chain, synapses. There's some exceptions down below, don't worry about that. But for the cranial nerves, synapses in the sympathetic chain sends the postganglionic neuron out, okay? Next, we look at parasympathetic, okay? Cell bodies are in the brainstem or sacral spinal cord. Don't worry about sacral spinal cord for now. So we have a long, relatively long presynaptic, this picture isn't great, these should be a lot closer, a relatively long presynaptic neuron, okay, synapsing, and then the post ganglionic neuron going to the effector organ. Okay, so that's the basic setup we're working with. Now let's go into a little more detail. But first, this is how you get saved by anyway. So like the sweat here, that's actually sympathetic too. So I was thinking about it like this isn't right, but I got fooled by that once, but now I know sympathetic is sweat, even though it's acetylcholine. So anyway, whatever. Spinal nerves. So these are the ones that attach to the spinal cord. Okay, peripheral nerves communicating with spinal cord. There are 31 pairs of spinal nerves. They're named for one of the adjacent vertebrae. In the cervical spinal cord, they're named for the vertebrae below the nerve where it exits the spinal cord. And then from the thoracic on down, they're named for the vertebrae above. The reason for that is because there's a C8 spinal nerve and there's no C8 vertebrae. Okay, so it switches right there. Okay, so this is the dorsal and ventral roots, the Dave thing we were talking about. So dorsal being afferent, carrying the sensory neurons into the spinal cord, and then the V and E in Dave is the ventral efferent, exiting the spinal cord, carrying out. And then the union of this dorsal and ventral root will form your spinal nerve. You guys have been looking a lot of ventral rami. Those make up like the brachial plexus and other larger nerves. The dorsal rami are usually smaller. Dorsal root ganglion is also important to know. That's where the sensory neuron cell bodies are for the spinal nerves. Any questions about this? Okay. Yeah, so spinal nerves, both sensory and motor, because they have this union thing going on. It really shouldn't say M1s. It should say all M, all M, because I'm still afraid of it too. But anyway, hope that's not too traumatic for you. Okay, let's talk about the most interesting, but also probably the most complicated thing, cranial nerves, okay? Don't freak out when I show you this. There are a lot of branches, there's a lot of names, there's a lot of text, but don't look at the text, okay? Listen to my voice and I will lead you through the darkness to the other side, I promise. All right, it'll be all right. So cranial nerves, what are they? They are peripheral nerves that communicate with the brainstem or the brain, okay? Not the spinal cord. There are 12 cranial nerves. They are numbered 1 through 12. They use Roman numerals, okay? So that's all the names right there. So unlike spinal nerves, they don't always just carry sensory and motor, okay? They can carry sensory, they can carry motor, they can carry parasympathetic, they can carry a combination of any of those three, okay? But thankfully we have a little mnemonic that I like. So that's it. Sometimes people say butts instead of brains, but whatever floats your boat, you know, whatever is near and dear to your heart. So anyway, so this will be important. So there's 12 words. They are named. So S would be sensory, M would be motor, and then B would be both. Okay, we'll go through each nerve and we'll talk about it. Anything before we get started?
And this stuff is all going to be stuff that is in HENT.
This is a preview.
So don't like get really stressed out about it. It's just like trying to prepare you a little bit for it.
So this is, yes, it'll be okay, I promise. So this is the brainstem, okay? Looking at where all the cranial nerves come out. Don't worry about this for now. If you're curious, refer back to this in neuro and HENT, okay? Don't worry about it now. Cranial nerve 1, okay? I'm gonna ask questions. What is another name for cranial nerve 1? Olfactory, good. Is it sensory, is it motor, or is it both? Sensory, good. Some, right? Our favorite. What does it do? Smell, very good. It'll get harder, but it's okay. Ignorance is bliss. So looking at the cranial nerve, I took all these pictures from Netter's Atlas. I gave you a link at the end. This is how I learned the cranial nerves, is I just stared at these pictures, okay? So I don't know what will work for you, but it worked for me. And if they're great pictures, I'll show you why. Okay, so cranial nerve 1, we have the olfactory nerves coming up through the cribriform plate up into the olfactory bulb, and then that goes back to the brain, okay? Only sensory, okay? That's probably why I'm so like messed up. I don't know what the critical concentration is of inhaling like, you know, a Sharpie, but I probably reached it because it was great. So I don't remember much from 5th grade, actually, now that I think about it. Okay, cranial nerve 2. What is it called? Optic, very good. Is it sensory, motor, or both? Good. Say, right there. What does it do? Vision, good. Okay, another picture. So it's coming out right there, okay? The thing about cranial nerve 1 and 2 is they're the only two that go directly to the brain. They bypass the brainstem, okay? All the other, I don't know, 10 go into the brainstem, okay? They will beat this into your brain a lot. For now, just appreciate that you have this optic chiasm here where you get a crossing of the neurons and then it relays back to the occipital lobe, okay? And that's where your visual processing system is in the back of your brain. They're gonna try to fool you, but don't get fooled. There's a chiasm cross, okay? Crosses. So anyway. Next, cranial nerve 3. What is it called? Oculomotor, very good. Is it sensory, motor, or both? Motor, yeah. Thankfully, it's named motor. The motor's in the name, so that's nice. That helps. Yes, Mary. Okay, what does it do? It's got. This is like a little. Okay, now we're getting a little more tricky. So, what is its motor function? Moves the eye. Good. So it does 4 out of the 6. There's 6 muscles that move the eye. It innervates 4 out of the 6. Okay. It also opens the upper eyelid. Okay. So when you like googly eyes somebody, that's your oculomotor nerve opening the eyelid. It also has a parasympathetic function. Does anyone know what that is? It's a weird one. It is a pupil constrictor. Okay. So parasympathetic nerves. So there's no sympathetic component to any of the cranial nerves. Okay. Sympathetic components. The sympathetic nerve does its own thing in the head. Okay. But you will see some parasympathetic components to these nerves. General principle. Okay. We'll do a picture after I do 4 and 6. Okay. Because it all ties together. What's cranial nerve 4? Trochlear nerve. Good. Somebody said it. Is it sensory, motor, or both? Motor. Good. Okay. And then, so that's our mnemonic. So some say money 4M. Got it. What does it do? It has one function. It innervates one muscle. Does anyone know what the muscle is that it goes to? Superior oblique. Very good. So we'll go over eye movements. And have they gone through this at all with you? No, not even a little bit. Okay. All right. They did trigeminal. Okay. We'll get there. This facial. Okay. All right. Well, I saw like intro to cranial nerves and I didn't know what that meant. So, okay. But anyway, so don't freak out. Okay. No freaking out. All right. And then cranial nerve 6. Okay. It's called the abducens nerve. Okay. It's another innervator of the eye. It's a motor nerve. And it abducts the eye. Okay. Let's look at the picture. So you have 6 extraocular muscles, okay, that move the eye. So 4 of them are innervated by the oculomotor nerve. Okay. We have the superior oblique. There's little numbers here. So inferior oblique, superior rectus, inferior rectus, medial rectus are all oculomotor. I think I said superior oblique. That was a mistake. So superior oblique is the trochlear nerve or cranial nerve 4, and then lateral rectus is cranial nerve 6. Okay, they'll talk to you about this. Don't worry about this for now. I wasn't sure, but when you look at the eye, just know that it's not completely on center, unfortunately. So it's not that the superior rectus only moves the eye up. You can see it's kind of off center. So when it contracts, it actually moves the eye up and in. So it's kind of annoying, but that's the way it's set up. So refer back to this when you do your eye movements. They'll have like a whole lecture on this. But this is the general setup. Okay. It's gonna be a big picture, but don't freak out. Okay. Don't panic. No panicking. General principles. Okay. When you do HENT, I want you to come back to this picture and have an idea of how to work through it. Okay. I don't want you to memorize anything right now. So what I want you to appreciate here is we have the eye, okay? We have the extraocular muscles attaching into the eye. The 3 nerves we've talked about that innervate the extraocular muscles are the oculomotor nerve, okay? The trochlear nerve and the abducens nerve, okay? Those are your three nerves, and they're all pictured here. They're all primarily motor, like skeletal muscle motor nerves, okay, which is indicated by this red line, okay? Dark red is skeletal muscle. So you can see the oculomotor nerve here traversing and innervating 4 of the extraocular muscles, and then this one, that opens your eyelid, okay? Next, we have a trochlear nerve coming out here, innervating the superior oblique, okay? And then we have abducens nerve here coming around, innervating lateral rectus, okay? So this picture has everything you need. Don't freak out though, okay? So next we have also, remember I said there was a parasympathetic component of the oculomotor nerve that goes here and does pupillary dilation or constriction, excuse me. So, but when they teach you this stuff, feel free to come back to this picture, okay? Okay, so something you guys maybe have a teeny bit of background on, cranial nerve 5. Does anyone know what it's called? Trigeminal, good. Is it sensory, is it motor, or is it both? Both, good. I had somebody said it. So yeah, go back to our mnemonic. What does it do? What's its like major sensory role? What does it do? Face, good. So all the sensory innervation to the face is trigeminal nerve, okay? It also does like some of the mouth, and also does the cornea, which is kind of weird. So when you get something in your eye, that's your trigeminal nerve complaining. There's also a motor component. What muscles does it do? Mastication, good. Yeah, so your chewers. Okay, it's a big one. It's huge. Yeah. It branches into 3. I'm going to let Matt focus on this mostly, but there's 3 divisions: ophthalmic, maxillary, mandibular. Okay, they innervate different parts of the face. Mandibular also does muscles of mastication. Okay, so which makes sense because it's down here, right? And that's where your chewers are. So, okay. Once again, don't freak out. Okay. My meme, no. Okay, so we have a big sensory component. It makes sense, right? It's sensory to the entire face. Okay, so there's a lot of blue. There's a lot of afferent fibers. Okay, so what they do is they run around and they hitchhike on the ophthalmic nerve, the maxillary nerve, mandibular nerve to innervate the face. Okay, that's all this blue. Then we also have, what did I say? The muscles of mastication coming off of the mandibular nerve. You can see that here with this red line going down. These are your muscles of mastication. And that's pretty much it for the trigeminal nerve. It's just a lot of little branches, but keep it simple, okay, for now. So, and the other thing, Drew, remember what we said with sensory, we have a ganglion outside the CNS, and that's your big ganglion, the trigeminal ganglion right there. It has all the cell bodies for pretty much every sensory nerve, okay, from the face. Not pretty much, every sensory nerve, okay. So, come back to this if you learn by pictures. Sorry, it's really blurry. But anyway, yeah. Okay, cranial nerve 7, okay, halfway through. What is cranial nerve 7? What's the name? Facial, good. Is it sensory, motor, or both? Both, good, yep. It does a bunch of, it does a couple weird things that make it both. Brother. Major functions, okay. Its motor function, what does it do like with the face? Facial expression muscles, good. It has a parasympathetic component. Does anyone know? If you don't know, that's totally fine. I don't know if they taught you or not. It does some secretions, okay? It goes to a couple of your salivary glands, and also goes to your tear gland, the lacrimal gland in your eye, okay? So, it also has a sensory component. It's taste from the front 2/3 of the tongue, okay? So it does a bunch of weird things. And it comes out here beneath the pons. Okay, another big picture, but everything I said will be in this picture, I promise. So it's mostly a motor nerve, right? All the muscles of facial expression. You can see all this red, all these nerves. There's actually 5 branches that Matt's gonna talk about. I won't talk about those now. 6. Thank you. Sorry. That's why he's the anatomy guy. And then we have a small sensory component from the anterior 2/3 of the tongue coming here. And remember, with sensory neurons, we have ganglion. Okay, there's a ganglion right here. Don't worry about the name for now. And then we also have some taste fibers, or not taste, excuse me, parasympathetic fibers coming down to here and hitting a couple of the salivary glands. And then also up here going to the lacrimal gland. Okay, it's all here. You can come back to it. Okay, don't worry about it for now. There is this branch called the chorda tympani that's pretty high yield that attaches to the, it carries some facial nerve fibers over to the trigeminal nerve. The beeb. Does anyone know what the beeb, what he's got going on here? Yeah, it's a Bell's palsy, but he had like a herpes zoster reactivation in his face. And so like it gave him like this like temporary Bell's palsy. And so every time it's like a shingles thing, it like got into his facial nerve and then it like made his face weird. So the only reason I know that is because my sister kept telling me about it. So, but I figured it'd be fun to include it. So I don't know what that was. I don't know, technical problems. Sorry. Okay, cranial nerve 8. Anyone know the name of this one? It's fine if you don't. We haven't talked about this. Okay, it's like vestibulocochlear. Okay, it's a sensory nerve. It does hearing. Okay, hearing and then your sense of balance. Okay, this will be. I guarantee you, this will be covered again. Okay, this is just throwing it out there for you once. Okay. It actually, it's really close to the facial nerve. They kind of come out together. In the lab, it's really hard to tell them apart. Actually, when you're getting into the brainstem, you like they kind of look like one thing. So this is just another little schematic. So sensory over to your cochlea for hearing, and then sensory over to the vestibular system for balance. Okay. So yeah, you never know, I guess. When anyway, sorry. Cranial nerve 9, okay. I'm just gonna breeze through this because you guys haven't. So this is the glossopharyngeal nerve. It does both. It's kind of like the facial nerve. It has some weird stuff going on. Its major function is sensory. It does taste, and from the posterior 1/3 of the tongue, it does sensation. So, but don't worry about that for now. Sensation from the oropharynx, cranial body, yeah. It does the parotid gland. So the facial nerve does all the glands except the parotid, and then glossopharyngeal does the parotid. It's weird because the facial nerve goes through the parotid gland, but it doesn't innervate it. It's really annoying. I don't know why that's like that, but anyway, in lab you'll see it. It also does one muscle, the stylopharyngeus, and I'll show you. This is just another schematic with all that information. It's responsible for like the afferent limb of the gag reflex. So if like something like touches the back of your throat, and so it carries the sensation for that. And then the vagus nerve comes back and constricts your throat muscles. So come back to this picture if you like pictures when they talk about this, but I don't need to go into details. Yeah, it's concerning, I guess. So, okay, cranial nerve 10. This is a big one. I really don't think we need to talk about this now, but does anyone know what the name of it is by chance? It's a vagus. It's a big nerve. Okay, it does a lot of stuff, so it does both. Therefore, brains or butts. Major functions. Whatever. You'll get this vagus nerve stuff in cardio and GI. So don't worry about this for now. You got plenty of other stuff to study. And there's your picture if you want to look back at it. There's just all kinds of different fibers. You don't need to know everything on here for now, especially anything below the neck. The thing I will say is that it does your speech muscles. So, and it does that through the recurrent laryngeal nerve, which has an interesting path. It actually takes this route down, beneath the aortic arch, and it comes back up and it goes into the larynx. So it's kind of a weird route. So I like to assume it's the first one, hopefully, but you never know. Actually, that doesn't make sense. I'd like to assume it's the second one, not the first one. Whoops. Okay, almost done. Cranial nerve 11. Does anyone know this one? Spinal accessory, good. Is it sensory motor or both? Motor, good. It only does two things. Innervates the trapezius, so shrugging your shoulders, and that also does the sternocleidomastoid, so turning your head side to side. It's your big muscle here in the front of your neck. Okay, and this is its path. It actually starts kind of below the skull, and it comes back up through the skull and then comes back out again. It's kind of a weird takes a little U shape. So SCM and trapezius. And then this one. Excited to test this one out one day. We'll see what happens. And then lastly, the hypoglossal. I gave it away. It's cranial nerve 12 motor. Does anyone know what it does? No, tongue. Okay, so it moves your tongue around. So kind of fun. It's the last one. So this is just another schematic going into the tongue. Okay, moving your tongue. So if you like damage one of your hypoglossal nerves, if you damage it, it'll like point towards the one that's damaged. So Miles here has a left hypoglossal nerve injury, I think. Why else would she stick her tongue out like that? I don't know. So, yep. And then here we go for just another schematic. And that's it for me. So come back to that for HENT if you want. It helped me. So, and then one more. So don't believe it when they say it, especially if it's your mom. That did not go well. It was like 3 years and can't live it down. Matt, you ready? Sorry. All right, we'll pull up your presentation here.
Do you guys need a break at all? Or are we good to keep going? All right.
You guys are troopers. I have the attention span like a squirrel. You can sit here for 8 minutes, then I gotta go.
Why 8?
I timed it.
Time to what?
My attention span. I know. It used to be 23 minutes.
Still good. So I'm still rolling.
Yes. All right, just make sure. Yes, we're good.
All right, good. So I've got the anatomy for, I think it's just this week. I don't think any of this stuff is going to be next week, but there'll be another SI session to go over the neck. For next week with the anatomy, just kind of just a general overview of this stuff. I'm not going to go too crazy with the anatomy because again, it's a lot of times just up to you guys to memorize it all. You can't just know anatomy, you got to practice it. But I picked out some of the like high yield stuff, as well as just kind of some ways to learn the skull that I think are kind of the most helpful. I don't remember exactly what they asked about the skull this block versus next block, but over the two, you're going to learn kind of everything about it. So what? Yeah. Already? Oh, okay. Well, the masseter is one muscle that's important. So we'll go through all the face and the stuff, but the skull itself is something to start with. So it's gonna go. There we go. Don't start here. This is a very terrifying handout that they at least gave us last year. It does have all the information that you could really want to know, but it's too much information to start with. So rather than starting here, end there. It's a good ending point, a good way to summarize kind of everything you've learned. Start with the big bones first. So learn the general layout, learn the, 7, 8 bones, whatever it is, first. And then from there, kind of build. So each of those bones has some very like specific features, different framing, different processes that come off of it. Learn those. So once you have the framing and the processes down, then add in the structures that kind of go through the skull. So the cranial nerves, as Dan taught us, the arteries and the veins, and then put it all together. So take it step by step, put it all together, and then you can come back to this thing and be like, oh, okay, I know the supraorbital notch is where the supraorbital nerve and artery come out of, rather than being like, what the heck is any of this talking about? And also just another tip, were you guys given the skulls again this year to like practice on? Yeah. Okay. Take a pipe cleaner and just kind of like poke the pipe cleaner through the different framing to learn it from all directions. Because within the practical, what they'll do is they might be nice and have the skull, sitting there on the desk, just right side up, or they might be really mean and have it turned on its side or upside down or whatever. And so you kind of have to know it from all different perspectives rather than just like that normal top-down approach. So do that, you'll be good. It honestly overlaps with a lot of the other anatomy, so it comes together pretty quick once you guys start working on it. So starting with the skull, just the big bones. So there's 8 of them. sphenoid, ethmoid, frontal, 2 parietal, 2 temporal, 1 occipital. This is the sphenoid. What? Oh, might be a question. Ooh. Dan, what do we do?
Maybe enable editing.
Or click stop sharing and reshare it.
Oh, it's in that. That's
Oh,
weird. All right. Is that better? Online, folks. Perfect. Awesome. That's what we like to see. So just again, here's the skull. So 8 big bones. And then this is kind of the funky looking one. I don't know if they did it to us, but I know in past years they've just like stuck the sphenoid onto the table and been like, what's this? So recognize that this is actually a bone that traverses from one side to the next. And then the orbit is also another spot that they like to kind of tag different things in just because there's a lot in a little area. So kind of understand the different areas of the orbit. Nose, then you got the little tiny palatine bone. Maxilla makes up the base. Zygomatic is the lateral aspect. And then ethmoid and lacrimal make up the medial aspect. And then sphenoid's posterior and frontal is going to be superior. Oh, I click again. Here's just another view of that. Sutures are another thing they really like to ask about. Either they're going to tag it or for sure we'll ask about it at some point. So understand the sutures. So mid-sagittal suture, lambdoidal is the funky one in the back, and then the coronal one in the front. And it kind of, if you guys remember the planes that they kind of taught you right at the beginning of anatomy, it aligns essentially with that. Same thing. And then again, here's just another angle of the skull itself. So this lines up with Dan's cranial nerve stuff, but is certainly not everything that goes through all these foramens. So I wanted to make a note of that. This is only the nerves. Each of these things generally has some more stuff that goes through it. So make sure you go back and learn the like arteries and veins as well. Limited time, didn't really want to go through everything. So I kind of just picked the big things here, of which the nerves are a big one. So out of these, I guess 3 like biggest ones that we've been asked about are the ROS ones. So rotundum, ovale, and spinosum. And what they like to do, rather than just say, what is this foramen, they'll tag the foramen. They will want you to say what goes through the foramen. So understand that, rotundum V2, ovale V3, and then this one, if they don't ask about it in this block, they'll ask about it in head and neck. But the foramen spinosum is where the middle meningeal comes out of, and that artery is something they really like. It's also a source of brain bleeds too, just because it's kind of close to the surface. So if there's like a head trauma to the side of the head, sometimes the middle meningeal can be affected there, and you'll have brain bleeds as a result. So these are kind of the big ones. I mean, but they're all, and one that's not even on here is like foramen lacerum that I know they've tagged before. This weird structure here, the curviform plate. So again, just take a look at it. This is a good starting point. These are things that I feel like are important, but as a whole, there's a lot more to the skull that you'll learn in the next 6 weeks or so. Actually, probably longer than that. You'll keep learning it into neuro. So it's something that it's good to learn it now because it's going to keep coming back, but don't sweat about learning everything now just because it's going to keep coming back. Along with the skull is the mandible. It's the coronoid process, not coracoid process. If you write coracoid like I did last year, it's wrong. So coronoid process of the mandible. Ramus, the foramen of the mandible, this is something, did you guys have the infratemporal fossa today? Or is that on Friday? Okay, so Friday you'll see this thing. Pretty important structures, important stuff that goes through it. Mylohyoid lines, another thing that will come up. Lingula is going to be a good landmark. So you'll be able to feel that with your finger before you make the cuts on Friday to kind of open the mandible up. But understand, just look at the mandible. Don't forget about it because it's free game on your osteology for this practical. Any questions on the skull? Are we good to move on? Any chat? Nope. All right, cool. So the scalp, a lot of things going on. This picture looks horrible. It's actually not that bad. These are all things you're going to learn at some point in the next, 6 to 8 weeks. Just know that it's very vascular. There's a lot of anastomoses in it. Even the nerves kind of do a pseudo anastomosis where they all just kind of come together. So I would be surprised if they asked you anything like sensation wise on the scalp, just because it's kind of confusing and it can actually vary person to person, which nerve is affected where. What they'll do is they'll do the sensation kind of farther down into the neck rather than the scalp itself, just because there's so much of this like little nerve and whatever that comes up there. So extends from the superciliary arches, eyebrows, to the external occipital protuberance, and then the superior nuchal lines posteriorly, laterally to the zygomatic arches. Again, blood supply is from internal and external carotids, and there's a ton of anastomoses. As I was just saying, the anterior to the auricles ear is trigeminal nerves, which I guess that's these guys right there. And then posterior to the ear is going to be spinal cutaneous nerves, which you'll cover more so next week within the neck itself. So that'll come up and something you'll have to know for this block as well. Layers are important. Scalp is the mnemonic, makes it kind of easy. So skin, connective tissue, the aponeurosis, and loose connective tissue and periosteum are your 5 layers. The dense connective tissue is one that I like to highlight because that's going to be the vascular layer. That I think that was a question we got asked. I don't know. Which layer of the scalp has like all the vasculature in it? I think it was in there. It's important. Know that. Otherwise, just understand the 5 layers. Might have been prep you. Emissary veins are the guys that connect the skull inside to the scalp outside. Also can be like a source of infection. The infection control is kind of interesting with the scalp just because it's got so many different attachment points. So infection really can't spread anywhere but anteriorly on the scalp. As it says here, the frontalis muscle inserts into the skin rather than into bone. So it is going to allow infection to spread, but posterior and lateral, you're not really able to have the flow that would be required to have the infection spread that way. I think that's it on this. And then I think this was talked about. So subgaleal hematoma is bleeding under the aponeurotic layer. And so that one is going to cross suture lines because the aponeurosis is what that's going to more insert into the sutures. So this one, the aponeurosis covers everything. The periosteum inserts into the sutures. So the aponeurosis goes everywhere. So you can even over the sutures. So you're able to, it's a little morbid, but like squish the blood over the sutures, however you want to think about it. And then the cephalohematoma is going to be between the periosteal layers of the scalp and then the bone. That one, so here's cephalohematoma versus subgaleal hemorrhage. Since it's under the periosteum, that one's going to be confined to the suture lines. And usually this is in little newborn babies, not human, not like adults. So here's the cephalohematoma. See how it's constricted by the suture, where the subgaleal is over the entire region. Couple questions. Number 1, 64-year-old man diagnosed with an acoustic neuroma. So that's going to be a tumor of the 8th cranial nerve where it enters the temporal bone. What other cranial nerve that enters the same area, same foramen as the 8th is also going to be affected? Facial, nice. And then number 2, an infection in which scalp layer is most likely to spread? This one is a little confusing. That's a tough question. So that's gonna be the loose areolar tissue, just because there's not really anything to keep it in one place where the other ones have stuff to keep it in place. Another question, sustained a fracture of the middle cranial fossa following a fall from a height. Can have several nerves injured, except you just land the cranial nerve, so this one's kind of tough. So that's gonna be your hypoglossal. And then Number 4, an elderly man presents with severe pain beneath the left eye, radiating into the lower eyelid, the lateral side of the nose and upper lip. What nerve was involved? Any ideas? So this one is going to be the infraorbital nerve, which is going to be a branch of the 5th cranial nerve, which we'll get to. It's just kind of funny. So this is just all the facial expressions you can do with the facial muscles, which is what we're getting into now. So starting with the oral group. And actually one thing to note about these is we're going to cover most of them, but there's like a bunch of little tiny ones that we're not going to worry about. So don't sweat the little tiny, like there's one that's, I don't know, like 20 letters long or something, just kind of absurd. Don't worry about those. These are the big ones. You'll talk about them more in head and neck, but for now, this is all you should really need to know unless they have changed things in the last year. So the oral group, orbicularis oris, buccinator, and mentalis, and then zygomaticus, major and minor. You kind of just call them one because some people don't have both of them. They'll just have a major. And actually, this area here is what can help form dimples, oddly enough. The buccinator helps you chew, so it keeps food in the right place without you biting your cheeks all the time. And then the mentalis just helps you like move your chin around. And obviously orbicularis oris, which that is spelled wrong. Okay. That helps close the mouth. Just another view of those. Nasalis is going to be your big nose one. Like I was saying, there are a lot of like little tiny muscles that are like here, and then there's a couple here. Don't worry about those. Nasalis is kind of all you need to know for now. And then orbicularis oculi, same thing as orbicularis oris, but around the eyes instead. Here's a look at the like non-face muscles that are involved. So frontalis in the front, temporalis on the sides, and then you gotta work with what you got. And then platysma is in the neck. So that's going to be your really superficial muscle in the neck that come Monday, just be very careful. Try to not cut through it at first so you can see it, but it's like fibers thick. There's not much there. But it runs all the way up into the chin as well. All right, so innervation to muscles of facial expression, super easy, just the facial nerve. That's it, all facial nerve. Finally, something that is straightforward, but it comes out of the stylomastoid foramen, which is going to be like right here, and has 6 divisions, but there's really 5 that go to the face. So the 6th one that can kind of sometimes be forgot about is the posterior auricular. That's this guy here going to the back of the head. And then you have temporal, zygomatic, buccal, marginal mandibular, and cervical. And these all are just describing where it goes. So when you dissect the face, you're going to see the little spindly nerves going off, and there's not really a defined way to tell what those are. You just kind of figure out where they're going to. So if it's going to the temporal region, that's going to be a temporal branch of the facial. If it's going to the neck, the cervical region, that's going to be a cervical branch, and then everything in between. A nice, easy way to remember it is you put your hand up to your face, and then wherever your fingers end up is where, is where those branches are, and they're named the same. So I did that in the middle of the practical, and I'm sure people were like, what the heck is he doing? But it's helpful, and really does lay out kind of exactly where stuff goes. And then Dan talked about this. Bell's palsy is when you have facial nerve damage. One thing to note here is Bell's palsy is going to be different than a neurological cause, and you'll get into it in neuro, but Bell's palsy, like the entire face is going to be affected, where, and again, don't worry about this now, but just a nice thing to know. If just like one part of the face is affected, then it's probably going to be not Bell's palsy and will be like someone having a stroke. So Bell's palsy, whole thing, it's just going crazy. And it's because the facial nerve itself is freaked out for whatever reason. Kind of happens whenever. And then you also can get specific branches, but in general, the compression of the nerve, like at the origin, is going to be the most common way, or within like the parotid gland as well, which you'll see the parotid gland is kind of crazy. Facial nerve has an interesting course, and as Dan pointed out, it's going to be some sensory as well. More so special sensory than actual sensory. Oh, actually, I guess it's both, but special sensory is going to be just one thing that can be often forgot about. Is it on here? So it gives off the chorda tympani within the infratemporal fossa. And the chorda tympani is something you just need to know about just for the like exam questions, but also they really like to tag it. So if you see this little tiny thing coming from, the back of the infratemporal fossa facial nerve area and then joining up with the lingual nerve here, it's the chorda tympani. And that is going to give you your taste sensation to the anterior 2/3 of the tongue. And that's the chorda tympani right here. Oh, we have a chat question. It's frozen. Oh, what? What the heck? So aggressive. Why can't this just work? Online, is that any better? No. I don't know. Natalie, is your internet working?
Hi, sorry. It's like when you go to present, it doesn't present. It just stays like it looks like you're on slide 4, but
What?
now it's moving. I don't know. I'm sorry.
Now you're sharing your whole screen.
Okay, maybe that'll work. Not anymore. Let's go. All right. Good job, Kathy. All right. So as we were saying, chorda tympani, this guy here joining up with the lingual nerve, which is a branch of V3, the mandibular branch of the trigeminal right here. And that's going to go down within the mouth to kind of the tongue and the regions right there. This is where it comes out. There it is. Woo. There's also going to be the, where is it? The parotid plexus, which go to muscles of facial expression, like kind of more out here. Let's see what else is high yield on this. Parotid gland, yep. So yeah, starts posterior, so pontine medullary junction. It is split into roots. Don't worry about that right now. Posterior cranial fossa, then the internal acoustic meatus with cranial nerve 8, as we talked about earlier. Then through the facial canal, where there's a ganglion, which gives off the greater petrosal and nerve stapedius, as well as the chorda tympani, which is out of these probably the only relevant thing to you now. But head and neck, you'll be like, oh, I remember that. And then it goes out via the stylomastoid foramen to the parotid gland, and then out into just like everything else. Anything from chat? Nope, that's good. So there's the somatic/motor branch, which is all the muscles of facial expression, as well as these guys are going to be in your neck, which they'll talk about next week. So I'm going to skip over that for now, but that'll come up on Monday. And then you also have a parasympathetic part, which is so that there's parasympathetics to the pterygopalatine ganglion and submandibular, which go to glands. So the facial nerves involved in lacrimation. And then there's also just general sensory to this little area in the ear. I don't know if we have a picture of it. And then special sensory. So that's our chorda tympani, and that's going to be taste from the anterior 2/3 of the tongue, as well as the soft palate. Super high yield on this. Facial motor is probably the other high yield, and then the parasympathetic will be high yield once you start talking about these ganglia. But for now, just chill on it. Know it exists. I don't think you need to know about the pterygopalatine ganglion right now. So parotid gland is going to be this here, kind of. And so you can see the facial nerve going right through it. And usually it doesn't really start branching into the face until it gets through the parotid, or actually into the parotid, I should say. And so that is going to be something you'll pick through for the dissection. There's also going to be the retromandibular vein, which is right here, and the external carotid in that same just general region of the face. So here's the sensory. We talked about some of these guys. Parasympathetics, chill on that. I don't think you need to know it quite yet. And then sympathetics is also something that I really wouldn't worry about quite yet. Understand it exists, cervical chain ganglia is going to be the sympathetics that go to the carotid plexus, but you don't need to know all the details of it. These guys you do need to know. So facial artery is going to be the big blood supply. It's a really spindly looking thing, kind of wide, like winds through the face. It's about 2/3 of the way up the mandible. So if you're trying to find like a facial pulse, go like 2/3 up and it's going to be about right there. And then it branches off into the inferior labial, below your lip, superior labial, above your lip, and then angular, which goes up to your nose. And if they ask about, what's the terminal branch of the facial artery, the angular artery is the answer to that. And so that's going to be like right here, going up by the nose. This stuff, a little scary looking right now, but you'll learn it either, if not Monday, then come head and neck, where you learn all the different branches. So just understand, we're going to have a superficial temporal artery, and then there's a middle temporal, and then transverse facial, and some of these other guys. Superficial temporal is going to be the terminal branch of the external carotid, though. So that's something that's good to know. Oh, as well as maxillary here. The maxillary, you'll see a couple branches of that, I think, with your infratemporal fossa. So that's another one that I guess is relevant right now too. Here's just another kind of highlighting it. The maxillary is this guy here, dives kind of almost straight into the head, which is a little bit unique because everything else kind of just runs around, but this guy, he goes straight deep. And then the facial, here's the labial ones, and the angular, and then here's some of the supraorbital, supratrochlear guys. And then there's the external carotid. Another super high yield thing with the face is the danger triangle. So they always say don't pop zits that are around your nose. And the reason is because there are no valves in these veins. So there's a connection between the angular vein and the ophthalmic vein that then leads directly to the cavernous sinus, which is kind of in the middle of the skull. And that there's no valves there. So if something's infected on the surface, it can pretty easily go back to the cavernous sinus, at which point then there's like clots and other pretty major issues that can be had. So infections around there, not good. Oh, and just one point out, it's the ophthalmic vein. That's the one that leads, which can be kind of confusing. I think that was a TBL question maybe. Hopefully I didn't steal Kramer's thunder to come, but ophthalmic vein is the one. Here's our trigeminal. Other relevant cranial nerve out of the ones that Dan went through for this week. Did you end up going through a lot of this, Dan? The sensory stuff? Okay, I had to walk out. So cranial nerve 5, trigeminal, gives off the 3 branches, which each innervate a pretty distinct area. So based on what area is being tested, then you can kind of figure out which branch might be at risk of injury or had been injured or whatever. So the ophthalmic is going to be up by the eyes, maxillary by the maxillary bone, and then mandibular by the mandible. So they're luckily kind of self-explanatory. But then they also go by V1, V2, and V3. So just realize that these are the same things because they are used kind of interchangeably. This is the sensation pattern. Usually it's not going to be at the margins. It'll be, forehead, cheek, and jaw they'll be tested. Ophthalmic, wholly sensory. Maxillary, also wholly sensory. And then mandibular is going to be your sensory and motor. Your mandibular branch is going to do the muscles of mastication. We talked about foramen rotundum, foramen ovale, and I think superior orbital fissure was on there as well. Crazy looking diagram. This is scary looking. Don't worry about that. Here's the trigeminal, going to be more relevant again, come head and neck. So one of the questions we had before was infraorbital, and so that is a branch of the trigeminal. It's a branch of the ophthalmic division. Actually, no, just kidding. It's a branch of the maxillary division. And then supraorbital and supratrochlear, I think, are ones that might have also come up So these are going to be your ophthalmic branches. And then so for Friday this week, you're more worried about the mandibular component. So the mental foramen and nerve is going to be almost the terminal branch of that. So that's where it ends up via the inferior alveolar nerve, which is not on here. Okay. Oh, actually there it is. So inferior alveolar is going to be the big one you'll see when you actually like take a chunk out of the mandible on Friday. Trigeminal neuralgia is something that is not uncommon. Not really sure why it occurs other than there's demyelination involved sometimes. And then there can be pressure on the trigeminal root from an artery, but there's just a variety of things that this can be a result of. And usually it's V2 that gets most affected, and it's going to be bilateral pain. It's not, or no, unilateral pain. It's not bilateral because there's only one that's generally involved. And I'm pretty sure it's described as being like really painful, like debilitating pain almost when it's talked about in a question. So here's the infratemporal fossa. Lateral boundaries is going to be the ramus of the mandible. Medially is the lateral pterygoid plate. Anteriorly is going to be the posterior aspect of the maxilla. And then posteriorly is tympanic plate and mastoid and styloid processes of the temporal bone. So it's going to be like back in here-ish. Superiorly is the greater wing of the sphenoid, and then inferiorly is going to be the medial pterygoid muscle itself, which is not on here. A lot of stuff in here, but it all is generally kind of big, so you can see it, which is nice. So inferior part of the temporalis, lateral and medial pterygoids. The lateral pterygoid you'll be pulling out to get to everything else. It's going to be a superficial thing, maxillary artery, pterygoid plexus, and then mandibular. These are all just different nerves that are going to be in there, as well as the otic ganglion, which you may or may not see. Sometimes it's kind of tough to see. So mandibular nerve, V3 is the big one. Gives off the auriculotemporal, inferior alveolar, which is going to be the big nerve in there, travels within the mandible, and then the lingual and buccal nerves as well. Lingual is going to be your other big one you see. That's the one that the chorda tympani joins up on. That goes towards the tongue itself. The inferior alveolar stays within the mandible, exits via the mental foramen. And there's also a nerve to the mylohyoid, which you probably will see. That one's not super uncommon to be able to see it. So that just goes to a muscle in the neck that you'll learn about next Monday, I think. Then auriculotemporal is this guy here. So that's going to actually encircle the middle meningeal artery, which is kind of a unique structure, I guess. And so that is a really easy way to identify it. So you see it circles there, auriculotemporal goes up, general sensory to the TMJ auricle temporal region, as well as some parasympathetics from the otic ganglion going to your parotid gland. Too far. Here's another kind of scary looking picture. Just kind of summarizes some of what we talked about. Don't worry about some of this really deep stuff. That'll be head and neck related. But then, chorda tympani, middle meningeal plexus, auriculotemporal, some of that stuff's important to realize. And then lingual, inferior alveolar, these guys are important. So inferior alveolar, which we've talked about a little bit, that one is going to be when you're getting any like procedure on a tooth on the lower jaw. That is going to be what gets numbed. So the dentist will numb that one, which knocks out the pain to the tooth itself. And so it supplies skin and mucous membrane of lower lip, chin, gingiva, incisors, all that stuff. And then the lingual goes to the tongue, as we've talked about already. These guys, they'll probably tag one of the two on the practical. I don't think they'd tag both, but the way to kind of tell which is the lingual is going to be a lot more medial than the inferior alveolar. And so even if, the bone of the mandible is chipped away to where you can't really tell if it's going into the mandible or not, this guy's going to be a lateral one. This guy's going to be medial. And then finally, there's the muscular branches, which you won't see. They're super small. And then the buccal nerve, which you sometimes do see, and that just goes to the buccinator. I don't know if this was something that came up. I feel like it might have come up last year for us, is just like what kind of a joint is the mandibular fossa and temporomandibular joint. So it's a modified hinge. And so you get a little bit more movement than just a hinge would on its own. I'll let you go through the articulations. Out of the ligaments, the stylomandibular one is probably the only one that's super relevant. That is something you might see, you might not see it, but this is the one that you would likely see tagged rather than them like tagging the joint capsule or the sphenomandibular, just because it's in such an awkward place. Four muscles of mastication, pretty straightforward. Masseter just elevates, retracts. Temporalis elevates, retracts. Medial pterygoid is this guy here, elevates, but instead of retract, it protracts. And then lateral pterygoid is this guy here, and that's going to depress and protract as well. So these, they do like to tag as well. If you see something that's more superficial and has horizontal fibers, that's going to be the lateral pterygoid. And then if you see something that's a little bit deeper with vertical fibers, that's going to be the medial pterygoid. It's all mandibular nerve. Oh, and this is also super high yield. Just understand that the lateral is the only thing that actually depresses the jaw. The rest of them elevate it. I think we're getting close. So maxillary artery is broken down into three parts. Each one has just a couple, like it's got a lot of branches that come off, but there's some specific ones that are more important than others that we like to highlight. So the first part is the mandibular part. That's going to be your most superficial. The middle meningeal, as we talked about, will come off there, enters the foramen spinosum, as well as the inferior alveolar artery, which travels with the inferior alveolar nerve. And that is going to also go into the mandibular foramen. And off of the inferior alveolar is going to be the artery to the mylohyoid too. Sometimes you'll see it, sometimes you won't. That likes to travel with the nerve to the mylohyoid. Second part is going to be your deep temporal branches going to the deep part of the temporalis muscle. You also get pterygoid and masseteric, but ignore those. And then the other one is the buccinator artery / the buccal branch. That one, where are we at? Right here. Usually can see that one. So that's kind of going to go to kind of the buccal region. And then finally, the pterygopalatine part is going to be your posterior superior alveolar artery. That one, generally, if they tag anything that's like really deep in the infratemporal fossa, it's going to be this. That's like one of the terminal branches of the maxillary artery itself. These guys you'll talk about in head and neck when you actually do the pterygopalatine fossa dissection. Here's a mnemonic to remember all the different branches. Again, highlighted ones are the ones that are important and the ones that likely you'll be assessed on. I would be pretty shocked if they decided to tag anything other than those five in this region. So here's a couple questions. So 64-year-old, and I'm going to preference this. I don't really like this question, but 64-year-old woman is unable to open her mouth or jaw because of tetanus resulting from a penetrating wound from a rusty nail. Which of the following muscles would most likely be paralyzed? Again, I don't think it's a good question, but that's going to be the lateral pterygoid muscle, since tetanus is usually spastic paralysis, not flaccid. But anyways, lateral pterygoid is what opens the mouth. And then a couple more questions. So 46-year-old man visits a speech therapist complaining of dryness of the mouth, performs a swallowing study and finds that he doesn't have saliva secretion from the submandibular gland, and that indicates a lesion of which of the following nerve structures? Think about it, think about it. And then I think, actually, I don't know that one. We'll see what it says. And then a young girl complains of dryness of the nose and the palate. This would indicate a lesion of which of the following ganglia? So chorda tympani for the first one, and then pterygopalatine ganglion for the last one. Ignore that. You don't need to know that right now. The chorda tympani one, a little more relevant, but the number 6, don't worry about that. And that's it. Any questions here or online? Sweet. Thanks, guys.
Yeah.